Thank you very much, and thank you for your kind invitation, and congratulations to your research program. And je m'excuse, je ne parle pas français. Je parlais pour 4 ans dans l'école, mais j'ai tout oublié. So, d'accord, aujourd'hui, I switch to English. I'm sorry. And I will have this presentation and talk about the register. We will talk about the working methods. I will show you some results, and then we end with what have we done with research. So the Swedish Register of Palliative Care, it's a national quality register. It was established in 2005 when the Swedish Medical Association for Palliative Medicine asked 4 physicians, I was one of them, please construct a quality register for end-of-life care. Okay, we said 20 years ago, where should we start? Should we start when the patient is recognized having the palliative care needs? No, that's too difficult. We will start with a definite point, the death. And then we look backwards 1 week. What about the quality of care during the last week in life? And this was quickly developed and established, and today we are one of the 130 quality registers, national quality registers in Sweden, and all of them are financed by the Swedish Association of Local Authorities and Regions. And this register is used in all 21 regions in Sweden and the 290 municipalities. And the aims of the register is, of course, to improve end-of-life care. And all deaths are registered, so this is not about just specialized palliative care. It's about deaths in nursing homes, in their own home, in primary care, in hospitals, of course, in specialized palliative care, but the aim is to collect data from all deaths in Sweden, and that makes the register unique. You have a register in UK where they look on end-of-life quality in hospitals. In Denmark and Australia, they look in specialized palliative care, but there is no one looking as we do in Sweden on all deaths. And we can, through the register and the results, identify deficiencies in care. We can, of course, stimulate learning and improvement. We form a basis for research, and we can put pressure on decision makers. And that's important, as you all know. So we collect data through 2 web-based questionnaires. One end-of-life questionnaire that is filled in by the healthcare staff who cared for the person during the last week in life. And then we have, since 2020, a next of kin questionnaire where the family or the next of kin answer questions 4 to 6 weeks after the death. And some of the questions are similar to those who are answered by the healthcare staff in the end-of-life questionnaire. But there are also possibilities for free comments. They can say what they think about the ward, and they thank the nurse and the doctor, or said, oh, that was an awful doctor. And the different units, they get this back, so they can see what was the feedback from the family. And everything is aggregated and collected online, so you can immediately, when you have pressed the button, the data will go to the database and you will be able to look on it. So you can sit here in Paris and look online on your results, and if you are logged in, you can see your specific results and then compare with other likewise units. And this also makes it very unique, and it's one of the successes about the register that it gets so immediate feedback. It's not a yearly report, data was way beyond. This comes immediately. So the end-of-life questionnaire, it's about quality of care during the final week of life, and it's 27 questions completed by staff, and we have no missing data because they must answer the question. And some questions they can answer, I don't know. but we always got complete data. And here you can see what's it all about. It's about documented decision by the physician about end-of-life care. Was there an individual care plan? So what about communication? Did the person actually receive information about transition to end-of-life care? And did the person's next of kin, the family, receive this information? Was there assessment of pain, nausea, and other symptoms? And was there, during the last week, breakthrough of any of these symptoms? Pain, nausea, dyspnea, anxiety, confusion, death rattle. And if there were breakthrough, were these symptoms relieved? And in that case, to what degree? So was there drugs prescribed so that you could give if they had a breakthrough? Was there pressure ulcers? Did the nurse assess oral health? Did the patient get parenteral fluids or nutrition during the last 24 hours? What was the disease that caused the death? Did they consult with other specialists outside the ward? Did the patient die in the preferred place of death? And was there anyone present at the time of death? And was the next of kin followed up this talk with them afterwards? And the next of kin questionnaire, it's also web-based. We have 21 questions, and we have translated into 6 languages. And there are multiple choice questions, some of them much alike the end-of-life questionnaire, and there are free text. And we can compare the experiences of next of kin with the staff. And they are able to tell their story through this questionnaire. And as I said earlier, get feedback to the individual care units. And also here we have public access to aggregated data and even comparing. So what did the staff say and what did the next of kin say? And then we compare and show, was there agreement on, was there anyone present at the time of death, for example? Was there pain during the last week in life? And this is, of course, a tool for improvement and very much appreciated in the units because they get that instant feedback, can see what should we focus on. So here you have some questions. Did you feel that your loved one received good care? Did you receive information? Do you have suggestions for improved care? Did they have the symptoms, as we talked about earlier? Were you offered counseling after the death? And was there anyone present at the time of death? These are a few examples of the questions. And the results, 60% of all deaths, both expected and unexpected, are registered. And we have around 90,000 deaths in Sweden each year. So around 60,000 deaths are registered in the register. And see, you can see that there is a lot of physicians and nurses reporting to this register from almost 6,000 individual care units in the country. And the majority reports within 2 weeks. And we have more than 800,000 registrations since 2005. And today, actually 62. When I prepared this a couple of weeks ago, we had 60. But in the last week, there have come 2 other published articles. So now we have 62 published articles. And most of them are from external research groups. And we can see an association with the improved palliative care in Sweden. You can't say that this is thanks to the register, but as you can see, the top line there is, did the patient get information about transition to end-of-life care? And the one in the middle, was there a pain assessment? And the red line, was there a symptom assessment? And over the years, we can see improvement. And I don't say that this is thanks to the register, but they are, every time they are thinking of this when they do the registration. And so they learn and they can use it on the next person. So we think that we are part of this improvement. And we have national quality indicators in palliative care in Sweden. And here you see some spider charts. And here are some of the questions then displayed. If you look on the upper chart, someone present at time of death, care plan, information, these PRN, drugs, assessment of pain, assessment of oral health, and no pressure ulcers. And the red area is the goal which the National Board of Health and Welfare has stipulated. And the green area, what did they actually achieve? And you can see the numbers of persons on the right side, and this is 1 year from November 23 to October 24 when I prepared this presentation. And you can see in nursing homes, they are fairly good. And in hospitals, they have quite a lot to learn, especially about assessment and care plan. And who should be best in class? Well, specialized palliative care, and yes, they are. And they should teach this to the other care units in the country. So this is one way of displaying the results. What about research? 62 international peer-reviewed publications. We have 1 doctoral thesis. And we have a present research network that is very, very active. And we, for example, compare quality of care and symptom occurrence between different diagnoses and between different care settings. So what about the quality in hospitals compared to nursing homes and so on? What about the care for the elderly compared to young patients? What about patients dying in ALS compared to cancer, compared to kidney disease? Are there differences? Yes, we can show it. And of course, there are also lots of quality assurance projects. Many nurses around the country, they take out data and do quality assurance projects on their local unit and see what should we go on and improve. And here you can see publications per disease group. It's more about cancer, CVD, ALS, COVID. We have 7 publications on COVID. And, you know, in the beginning of the pandemic, during the summer 2020, there was a debate in Sweden whether patients dying due to COVID in nursing homes had a terrible death. Did they suffocate? Did they have a lot of pain and a terrible experience dying in COVID? And that was the public debate. And it's terrible. And then we actually, in May 2020, added a question to our questionnaire. Did the patient die due to COVID? And was there taken samples from the blood, checking for antibodies and things like that? And then in July, we could publish a paper showing that persons dying in nursing homes due to COVID had a very, very calm experience. They died rather quickly, and there was very little symptoms. But if you died due to COVID in hospitals, there was a lot of dyspnea and anxiety. So we stopped the debate thanks to the register and the data that we collected. And you can also see subjects, benchmarking, communication, looking on validity and things like that. And available then from the homepage, you can apply for data, and there are lots of external researchers applying for data, and they can see the variable list, and they have a description on how we do this. There's a publication list, there's an English summary, and from when you apply from the data, you get your data within 1 to 5 weeks, and it's free. And that's also one of the success factors. It doesn't take you a year to get this data, and it doesn't cost you a lot of money. We do this quick, and it's very, very appreciated by researchers in Sweden, and they do a lot of research on this. So upcoming, we will have add-on research questions to invited units. We have had one add-on questionnaire on the use of methadone in specialized palliative care in Sweden. And we have one of my doctoral students made his PhD on methadone in palliative care. We have presently a questionnaire about treatment of malignant ascites. We will have one about palliative care in hematological malignancies. What about the quality of care for those patients? So these add-on research questions to units who have said, yes, we want to participate. It's one way of collecting data on specific questions. And we start probably in 2025 voluntary add-on questions quarterly that will go out to everyone who register in the register. And the first one will probably be on palliative sedation, because it's 15 years since we did an update on how many patients in Sweden are receiving palliative sedation. So we have to do a new assessment of this, and then we will have, during 3 months, voluntary add-on questions around this. And we will probably have data from around 3,000 patients in specialized palliative care for 1 quarter. And then we can see, so how often is palliative sedation provided to difficult treatment symptoms? And we also retrieve data automatically from medical records so that the nurse and the doctor don't have to sit and fill in everything. They get some data immediately from the medical records. And we also have a yearly questionnaire on structure and process indicators to participating units. So how many specialists in palliative medicine do you have? Do you have residents in palliative medicine? Do you have physiotherapists, occupational therapists, and so on? And then we get structure and process data also. And we have seen that we are actually inspiring other countries. When we started to present this register back in like 2008, 2009, when we had quite a lot of data, there was no one in the world understanding what we did. They just sat like, and they didn't think about it. But now, UK, Iceland, Portugal, Australia is, what are you doing? We want to collaborate. Now, it took 15 years for the world to look up. But now we are inspiring others. So to conclude, this register forms the basis for measurement of quality of end-of-life care in Sweden. We can see improvement over the years, and we think that we are part of this, but we can't say it's thanks to the register. We provide instant feedback to the users, and that is very, very successful. And there is an enormous amount of data just waiting for you who are a curious researcher. So, is it possible to improve end-of-life care on a national level? Yes, it is. Thank you very much for your attention.
Alors, on a un petit problème pour les questions, donc on va proposer de faire une question pour Élise et une question pour Staffan. Et puis, ceux qui n'auront pas pu poser leurs questions le feront durant le déjeuner.
J'avais une question pour Staffan. Thank you so much for your presentation. Inspiring indeed. So do you plan to include measures for the patients, if possible, on the register?
That's the dream scenario. But we see that during the last week, we have done research on that, and it's very, very few patients that are able to answer. But our dream is actually that when the physician discovers palliative care needs in the patient, that might be 10 years before the death. When they discover that, they should open the register, tick a box, which is not there yet, because it's about GDPR and everything, you know. And when they tick the box, this patient is in the register, and then we could follow it. That's the dream. And then you can ask a patient, what about symptom control and so. But today we're just looking after death. But this is probably one way we will go forward.
Okay, thank you.
Just one question, because you said that 40% of deaths were not included in the register.
40% of all dying, yes.
They don't die, so they don't die in hospital, or they don't went in hospital, and they don't receive the case or not receive the questionnaire. But do you think they are similar to the others?
So we are doing this study now. So is it units that actually are registering, but they forget about this patient? Or are there units, especially in hospitals we know, that don't participate in the register? Or is this the unexpected sudden deaths, accidents and things like that? And right now we are doing this analysis, cross-linking with other registers in Sweden. So probably in a year we will have a good answer for that question. And we will do and see if what about quality in these patients compared to those that we register? And then we can talk about validity in the register.
Oui, bonjour. Isabelle Marcoux de l'Université d'Ottawa. Je vais poser une question donc à Madame Coudin. Merci pour votre présentation. C'était très clair et très intéressant. Jalouse aussi de votre système parce que nous, au Canada, c'est un peu plus compliqué. C'est géré par les provinces, donc d'avoir accès à ces données-là, c'est très, très compliqué. Je me demandais, parce que vous avez parlé de la cause de décès, suicide qui a été ajoutée, et je me demandais si vous recueillez des informations supplémentaires, comme par exemple au Québec, il y a, à partir du moment où la cause de décès est déterminée comme étant un suicide, il y a une enquête du coroner qui est faite avec, par exemple, des autopsies psychologiques qui sont des questions qui sont posées aux proches, aux soignants, tout ça, qui permet après, pour les chercheurs, d'avoir une mine d'informations pour ces cas-là. Donc, je me demandais si vous aviez un système comme ça.
Merci pour la question. On ne l'a pas pour les suicides. Pour les suicides, il n'y a pas de retour vers même c'est même hyper compliqué en réalité parce que ce qu'on reçoit, c'est donc les volets médicaux, mais il peut y avoir des obstructions et le volet médical peut ne pas être transmis dans le cas où il y a une demande d'autopsie. Mais passe par l'Institut médico-légal. Les instituts médico-légaux, des fois, ne nous retransmettent pas après derrière l'information. Donc, nous, c'est vraiment, à cet endroit-là spécifiquement, un problème. Mais en revanche, on fait ce même genre d'approche pour les morts maternelles. Alors avec la certification électronique, ça rend les choses beaucoup plus possibles. Mais quand il y a un décès, il y a aussi une cache-causée grossesse. Quand du coup il y a un médecin qui déclare, qui certifie une mort maternelle, enfin une mort avec un lien avec la grossesse, par certificat de dossier, il y a l'équipe d'épopée qui revient ensuite vers eux pour avoir des informations supplémentaires. Donc c'est quelque chose qui est de plus en plus, enfin c'est super et encore plus possible avec la certification électronique parce qu'on peut revenir vers le médecin tout de suite, enfin assez rapidement dans ce cas-là. Mais c'est pas encore sur les suicides et on pourra échanger là-dessus. Merci.
Peut-être juste pour ajouter, c'est qu'au niveau de la comparabilité ensuite des données sur le suicide, par exemple au Québec, il y a souvent eu il y a plus de suicides au Québec que dans les autres provinces canadiennes, mais le système de compilation est complètement différent et beaucoup plus serré, pointu. Donc, après, quand on fait des comparaisons internationales, mais que les systèmes ne sont pas les mêmes de codification des données, ça devient difficile, mais il faut en tenir compte.
Ouais, là, on est sur des... moi, je dirais que c'est de la collecte. Là. Donc, on a des biais de collecte, en fait, finalement, avant même la codification. Avant même la codification, c'est vraiment de la collecte. Effectivement, ça pose des questions, mais j'imagine qu'entre provinces du Canada, vous pouvez trouver aussi des écarts qui sont aussi documentables de la même façon. Et entre régions en France, on a des écarts qui sont hyper documentables. Et ce qu'il faut systématiquement faire, ça c'est aussi quelque chose qui est important, c'est qu'il ne faut pas regarder que les suicides typiquement. Il va falloir regarder les suicides, les autres causes, les intentions indéterminées, les causes inconnues. Parce qu'il y a comme par hasard, une relation très forte entre le fait de déclarer beaucoup de suicides et peu de causes inconnues. Voilà. Mais du coup, les variations géographiques, une fois qu'on a ces points de comparaison en tête, on peut quand même les approcher assez correctement.
Merci.